Hello and welcome. I'm Adele Gauthier from Breast Cancer Foundation New Zealand. Today we're talking about a new medicine and what it might mean for New Zealanders with advanced breast cancer. Sorry we're a few minutes late starting. Thank you for waiting. Before we get started, we'll just go through some housekeeping. If you have any technical issues, you can type details of your problem in the chat box at the bottom left of your screen and our support crew will be in touch. Or you can call the number you see there and enter the passcode to get some help. If you're having sound problems, you might prefer to listen on your phone while watching on your computer. You'll see some instructions as to how to do that at the bottom of your screen. You can use the chat box during the webinar to ask questions, which we'll get to later, and you can also chat to other people there. Don't worry about missing out on information while you're chatting. The webinar is being recorded and will be available on our website in the next few days. So today we're talking about a new medicine, Palbociclib, brand name Ibrance, and what that might mean for New Zealanders with advanced breast cancer. We have two panellists who are going to share with you, Dr. Richard Finn, who's here with me, and Dr. Anna Bashford, who is talking about where she's just finished a clinic. I don't think you can see her right now, but she is online and hopefully you'll be able to see her soon. Now, before I introduce Dr. Finn to you properly, I'm just going to run through the agenda and some context. This is a bit different from our other webinars, which some of you will have attended. And so just a little bit of a warning that there is some more scientific content in here that you're used to, but we'll get you through that with lots of explanations and hopefully come out the other end knowing more than when you went in. So we're going to be talking, Dr. Finn's going to be talking about the rationale for development of new drugs in breast cancer, so basically telling us about how Palbociclib came about and what it does. Anna Bashford is going to be talking about a Kiwi perspective on Palbociclib and what the considerations are that you might want to think about, as well as a new assistance program which might help it make it more affordable for some people. I will finish up with a little rundown of a couple of clinical trials that might be of interest, and then we'll get to the part that you're probably already waiting for, which is where you get to ask questions. So, a bit of background, just to set the scene. Don't want everyone to come into this knowing exactly where things stand. The medicine that we're talking about today, Palbociclib, is not publicly funded in New Zealand. It is MedSafe registered and PharMac is considering an application for funding. But we don't know what the outcome of that application will be. We don't know when it could be funded, and it won't be funded for people who have already received hormone treatment that has failed for them for metastatic breast cancer. So they've already started treatment and then have had to move on to something else. Even with an assistance program, this drug, like other new cancer drugs, is expensive. So that's just setting a bit of a scene for you. Now we're going to hear from Dr. Finn, and I'm just going to get right over that to his own introduction. He's an Associate Professor of Medicine in the Division of Hematology and Oncology at UCLA's Geffen School of Medicine. He splits his time between patient care and his research work, which has a focus on targeted treatments for breast and liver cancers. He's widely known and respected in the breast cancer world and has received many awards for his work. In recent years, he's led the approval of Palbociclib through clinical trials and preclinical stages right through to registration. So he's fresh off the plane in New Zealand this morning, in fact, to talk to local medical personnel and, I'm guessing, authorities about Palbociclib. And we're really fortunate to have him here for this hour. In fact, we're getting to hear from him before anyone else in the country does. So, Dr. Finn, welcome to New Zealand. Thank you very much for joining us. And we'll just let you get started.
Okay, thank you very much. Thank you very much for having me. Thank you for taking time to hear my presentation. And without a doubt, the work done by advocacy groups such as the New Zealand Breast Cancer Foundation is critical to move things forward. And this story, I think, really represents that in many ways. As you heard, I am faculty at UCLA in Los Angeles. I've been there for some time. My mother actually had breast cancer when I was a teenager and passed away, and that was a real driver for me to pursue a career in medical oncology and try to make a contribution. My mentor, Dennis Flayman, who many of you may know, made a pivotal contribution with the observation of HER2 being amplified in breast cancer, and I was fortunate to work in his lab as an undergraduate and then come back and do this story with him many years later. So with that in mind, we'll go to the first slide. And it's important to remember that breast cancer is not one disease. You can do one advance. There you go. Breast cancer is not one disease. Even though the pathologist looks at it under the microscope and says, yes, this is a cancer rising in the breast, we know biologically it's very diverse. And this map here of green and red is some of the work that identified that breast cancers are very heterogeneous in the laboratory. But even clinically, we still approach them as three large groups of diseases. There's the HER2 amplified group, which is about 25%, which we talked about drugs like trastuzumab or Herceptin are the backbone. There's about 15% of patients who will have triple-negative breast cancer, so they lack hormone receptors or HER2, and still at this point, chemotherapy is the backbone for those women. And then the largest group is this group of patients who are hormone receptor positive. ER positive is another way we refer to them. And the backbone of treatment for them for decades has been anti-estrogen treatment. Initially with drugs like tamoxifen, which block the estrogen receptor, and then drugs like letrozole or anastrozole, the so-called aromatase inhibitors that block estrogen production. And then most recently, drugs like fulvestrant or Faslodex, which are injectables that downregulate and destroy the estrogen receptor. And it's been known for a long time that while these drugs are very effective, eventually resistance develops, and we've been looking for new drugs and new ways to target this resistance for really decades. And the next slide. So one of the questions that comes up is, have we been improving outcomes for women with advanced breast cancer? And while it's hard to show that in any individual randomized study, in here these studies look at outcomes over decades, and we see that over decades, outcomes for women with advanced breast cancer have been improving. And likely that is because of the introduction of new drugs that are incrementally having benefit. And over time, we start seeing these improvements. So next slide. The real question for us is, can we do better, right? The real impact that we've seen in cancer medicine, not only in breast cancer, but I would say breast cancer is the prototype, has been translating observations made into the laboratory into the clinic. Chemotherapy type of approaches just take advantage of the fact that these drugs are poison, right? They kill cancer cells, but as you know, they also kill normal cells. And we've, in many ways, reached a plateau of what we can achieve with those drugs. One of the main focuses in my experience at UCLA and much of the field on the next slide has been to focus on this idea of translational research, which involves taking laboratory observations into the clinic, but at the same time taking clinical material back to the laboratory to study. And it's this engine that really has provided new insights into disease and things that are happening and impacting patients. There you go. So the topic of today's discussion is this drug Palbociclib, which is a compound that Dennis Slayman and I and Pfizer were collaborating on actually over 10 years ago now. About 2008, we started working with this compound, which is an oral pill that's designed to block the cell cycle. The cell cycle is a clock that regulates the division of every cell in our body. And one of the characteristics of cancer is that the cells grow uncontrolled, right? They continue to divide when they shouldn't. And one of the main regulators of that cell division pathway is these two proteins, CDK, cyclin-dependent kinases 4 and 6. And this drug was designed to block CDK 4 and 6. The big challenge, though, in drug development is if you have the best drug for a certain population, if you don't know who they are when you do a clinical study, then you might not hit the right population of patients. So on the next slide, this is kind of a cartoon of how Palbociclib works. The cell cycle has 4 phases, G1, S, G2, and M, or mitosis or division. And at each step of the cell cycle, there are proteins that regulate this transition. And importantly, for CDK4 and 6, they work on G1. And the idea of a drug like Palbociclib is to block CDK4/6 function to stop the cells from dividing. But the challenge for us has been, how would we know which type of breast cancer to give this drug to? And that's where our scientific collaboration initiated. On the next slide. On the next slide, you see some laboratory studies done at UCLA, and what we showed that using a large panel in the laboratory of breast cancer cell lines that represent all the different subtypes of breast cancer, that we showed that those that were most sensitive to this drug tended to be these ER-positive cell lines. And that is seen on the left side with the small bar versus those that are red and yellow on the other side that were very resistant, and those were the triple negative. This was not something we expected to see, but it set the stage for a clinical development plan of this drug in breast cancer. That is to say, to focus on the hormone receptor positive group. Next slide. So just to highlight the problem and to give you context for the curves you'll see in the subsequent studies with palbociclib and letrozole, is these are several studies that looked at various hormone treatments. And what you can see is all of these curves tend to have a very steep slope at the beginning. And in many cases, the two treatments overlap, which means they don't differ significantly. But what happens is there's a group of women who get started on anti-hormone drugs, and they progress very quickly. They are resistant. And we don't have good tests to identify who will be resistant. We don't have a molecular test. But it's been hypothesized that the reason these cancers are resistant is because there are various signaling pathways that are making them resistant. So with this in mind, and the clinical challenge of overcoming endocrine resistance, and the fact that we saw that this new drug, palbociclib, works in hormone receptor breast cancer models, we decided to design a clinical trial to test that hypothesis. And this is this whole idea of taking laboratory research to the clinic. So that study was the Paloma-1 study, also called Trio 18, done through our global network. And this study was an open-label phase 2 study, so women knew what they were getting, investigators knew what they were getting. And there were about 85 patients on each arm of the study. And we took postmenopausal women with hormone receptor or ER-positive breast cancer that were HER2 negative, and half of them got the combination of palbociclib and letrozole, and the other half got letrozole alone, standard treatment. Now, this study was meant just to validate our lab observation to then design a bigger study. But the results of this study were striking. And as you can see from these curves here, the control arm has that drop-off that we've seen in other studies. But the women who got the combination of palbociclib and letrozole had a very dramatic attenuation of that drop-off. And what we saw when looking at progression-free survival, which was the main endpoint, which is the time from a woman starting the study until her disease progresses, went from about 10 months with letrozole alone to over 20 months with palbociclib. So a 10-month improvement in PFS in this disease is pretty much unprecedented. And in reality, this data provided for accelerated approval of this combination in the United States in February 2015. So while it's new to New Zealand and many parts of the world, in the United States, we've actually had this now for 3 years. And what was very striking, with, you can go to the next slide, is that, is that not only did we slow progression, but we actually increased the response rate. That we saw women who got this drug, over 55% of them had actually tumor shrinkage. And what was really gratifying, on the next slide, is that we saw this with a very manageable side effect profile. That should be the next slide. So this drug is oral. It's dosed 3 weeks on with 1 week off out of each month, whereas letrozole is continuous. And the most common side effect we saw was neutropenia, or low white count. In fact, many women had white counts that we consider grade 3, or within that 500 to 1,000 per neutrophil count, which automatically for some people say, oh, this is like chemotherapy. But it's not like chemotherapy because the effect on the bone marrow is reversible and it's very short-lived. And because of that, we don't see a high frequency of infection. In this study, the frequency of neutropenic fever something that we all get worried about with chemotherapy, we actually saw none in this study. And as the drug is rolled out into bigger studies, we really see the incidence of that complication of about 1.5%, so very uncommon. And the other things that are associated with chemotherapy we don't see GI toxicity, diarrhea, we don't see mucositis or sores in the mouth, and the incidence of hair loss, severe hair loss, is very low. So this was very gratifying, and again, this result did not happen by accident, but was a well thought out scientific plan. Next slide. And so even though we got accelerated approval in the United States, there was still a commitment to do a large phase 3 study. This is the definitive test, which was placebo-controlled and blinded, and remarkably, the results were exactly the same. Now in a population of over 600 women, we saw that PFS went from 14.5 months with letrozole to over 25 months with the addition of palbociclib and letrozole. So that's still a 10-month delta, very consistent with the smaller phase 2 study. And if we think about that average survival for women with ER-positive breast cancer is in the 3 to 4 year range, that's after they get several different treatment regimens. Now in the front line, we're seeing progression out to 25 months. Next slide. And certainly when we introduce new drugs into breast cancer, a disease, especially advanced breast cancer, which is not curable, but we're helping people live longer, we saw that even though this drug added some side effects, it did not diminish quality of life. Quality of life was maintained throughout the course of the study, even though women were on the drug for a long period of time. And the drug's been studied in other settings of breast cancer. Here, it was studied in combination with the drug fulvestrant. And whereas the initial studies were in women who had newly diagnosed advanced breast cancer, and it was in combination with an aromatase inhibitor, we know that many women will progress on an aromatase inhibitor, at which time drugs like fulvestrant are effective. So in this study, the so-called Paloma 3 study, women were evaluated that took fulvestrant alone or fulvestrant plus palbociclib in a large randomized placebo-controlled study. And again, we saw a dramatic improvement in progression-free survival from about 4.5 months to over 9 months. So essentially a doubling of PFS. And so this is for women who never had it in the front line. So there are now 2 positive phase 3 studies, one with aromatase inhibitors like letrozole or anastrozole, or for women who had letrozole and anastrozole alone, there's data to support its use with fulvestrant. And again, you mentioned the regulatory environment in New Zealand, which I'm not as up to speed on, but in the United States, needless to say, the drug has approval on both indications. And again, the side effect profile in the phase 3 studies was exactly the same as we saw in the phase 2 study. So the data has been very consistent. And along those lines, what was reassuring is in this population of patients who had progressed on aromatase inhibitor, where they have more symptoms, actually the introduction of palbociclib and fulvestrant decreased their symptoms and improved quality of life. Where in the frontline setting, where women typically are not as symptomatic, we saw a maintenance of their quality of life. Here, in the second line setting, we actually saw an improvement in quality of life. And so now one of the very exciting questions is, what will happen when we move this drug from the advanced setting to the early breast cancer setting? So for women who have surgery, we know they're at risk for recurrence. The real question is, adding a drug like this to standard endocrine therapy, will that improve outcomes? And this slide highlights one of the studies being done in Europe. I think it has finished accrual and we're waiting for results. And these took women who got neoadjuvant or treatment before their breast cancer surgery, and based on their pathology at the time of surgery, they were considered high risk, and they were therefore randomized to standard endocrine treatment or 2 years of palbociclib with endocrine treatment. And the other large adjuvant study that's going on through the U.S. cooperative groups, again, is looking at palbociclib and endocrine therapy versus endocrine therapy alone. I think what I would like to see in the future is the removal of chemotherapy from the management of ER-positive breast cancer. We know that the benefit of chemotherapy in early-stage ER-positive breast cancer is very marginal, and now we have a drug that has a very high response rate, that has a very prolonged progression-free survival. I think the stage is right to try to answer that question, to say women will no longer need the toxicities of chemotherapy in adjuvant breast cancer. But we need to wait for the data. So there are other CDK4/6 inhibitors in development. They have essentially followed the development plan laid out with Palbociclib. These include a molecule ribociclib and abemaciclib, which are all now approved in the United States as well, with very similar labeled indications. So in conclusion, breast cancer as the prototype for diseases we treat really has benefited from the application of the science, understanding the disease, into the clinic. And this type of translational research has been pivotal to moving things forward. And as we've seen in the HER2 space by my colleague Dennis Flamen, the introduction of trastuzumab, and now the introduction of drugs like palbociclib in ER-positive disease, we're seeing that we're probably changing the natural history of advanced breast cancer in a significant way. And there's still a lot of work to be done. And next slide, I mean, a lot of this work cannot be done without participation in clinical trials. It's imperative. This slide just shows the timeline of evolution of ER-positive breast cancer, that until the introduction of Palbo in 2015, or even before that, everolimus in more advanced breast cancer with exemestane, the backbone of treatment had been just endocrine therapy. But again, I did not do this myself. Very much driven on the next slide, just all the clinical investigators. Like I was saying, we need patients to participate in clinical trials. Next slide. Our work at UCLA, Dennis's work, has really been driven by philanthropy. The Revlon UCLA Women's Breast Cancer Program has really made a big difference for this. And the last slide is just to acknowledge all the people I've worked with. So thank you very much for having me. I hope this was useful.
Great, it certainly was. Thank you very much, Dr. Finn. Now we're going to hear from Dr. Anna Bashford, an oncologist specialising in breast cancer at Auckland City Hospital. Some of you will have heard her at one of our previous webinars. Some of you may even be her patients. We always hear from Anna's patients about how great they think she is, so we really appreciate her taking the time to join us on a busy clinic day. Anna, we can't see you, but I'm pretty sure we can hear you. So from your perspective, where does palbociclib sit among the suite of offerings for people with advanced ER-positive breast cancer?
Well, thanks, Adele. Can you hear me, hopefully?
Yep, that's very good.
Yep, great. And well, I'd like to thank Dr. Finn for such a fabulous summary of the advances with this amazing drug and family of drugs. And I think from a New Zealand perspective, we're very excited that palbociclib offers another tool that can help extend the duration of response to our hormone treatments such as letrozole and fulvestrant. And the patients most likely to benefit obviously are those with stage 4 or metastatic breast cancer, and also those with locally advanced or stage 3 disease, because these are the patients that were included in the trials that Dr. Finn has already summarised. And as he's alluded to, we also hope in the future that we may be able to use this family of drugs in early breast cancer as well, in the adjuvant and neoadjuvant setting. But at this stage, those with metastatic and locally advanced disease should definitely talk to their oncologist about this option. I think what really makes it exciting to us is that it's an oral medication, so it means that patients can avoid intravenous treatment for longer, and it's really well tolerated, which, as Dr. Finn's alluded to, is important from quality of life perspective. It can be provided in the public hospital, but unfortunately patients still need to pay for it, and the fulvestrant if that's the combination they're going to go forward with. But in terms of coming to hospital for appointments, there'll be no doctor's fees. So for our Kiwi patients, it may mean some extra visits to hospital and some extra blood tests, but I really think the biggest downside is the cost, especially if they're paying for the fulvestrant. And it is a bit of a double-edged sword, because the longer patients respond to the drugs, which is obviously a good thing because they're living for longer with a better quality of life, that has implications for cost, because the longer you're on the drug, the more expensive it's going to be. And Palbociclib at the moment is around $5,750 a month, and we'll hear shortly more about the assistance program. And Faslodex around $3,900 for the first 6 weeks, and then $2,600 a month thereafter. Costs can vary, so again, talk to your doctors about that. And really, in summary, I think it is a complicated area. There are a lot of different options available to our patients now, thankfully. So the big take-home message is talk to your medical oncologist about what the best option is for you.
Great. Anna, are you going to run through this slide?
Yeah, I'm happy to do that. Thanks, Adele. So this week we've been really pleased to find out more about the Palbociclib Assistance Program, which is a compassionate access program, and it's offered by the drug company. Patients to be eligible need to be New Zealand citizens or residents, and they need to have hormone receptor positive, HER2 negative, locally advanced or metastatic breast cancer, and be able to take Palbociclib in combination with either the aromatase inhibitor letrozole in the first line or fulvestrant in the second line or later, and that's as it was done in the clinical trials. The announcement is that patients do need to pay for the first 8 packs of treatment, so that's the first 8 months at around $5,750 a month. And then following this, if they are still continuing to have a response to treatment, they'll receive the next 4 packs for no charge. And if you're taking Palbociclib as second or later line treatment after previous hormone therapy for advanced breast cancer, you will need to pay for the fulvestrant component every month as well. And then after 12 months of successful treatment, the process starts again, and if you're still responding to treatment, the access program holds. If you're currently a patient purchasing Palbociclib in New Zealand, the packs that you've bought already will count towards that 8 pack payment cut-off, but not if you've sourced the drug from overseas. And if you're being treated privately, you'll still have to pay doctor and clinic fees for that private care when the Palbociclib is given for the 4 months without charge.
Great. Thank you, Anna. I'm sure we'll have some questions on that. Before we move on to questions, I'm just going to give a very quick rundown of a couple of clinical trials that might be of interest to some of you out there. The first one, Monarch E, is for Ibrance, which is one of the other new drugs that Dr. Finn mentioned, so a similar drug to Palbociclib. There's a trial currently on in Auckland, Waikato and Palmerston North for this drug for patients with stage 3 early breast cancer that is ER positive and HER2 negative. You can see there that there are some eligibility things there about the size of tumour and the grade and so on. You have to meet one of those criteria as well as having the stage 3 breast cancer. And then the trial randomizes you to either receive standard treatment or to receive standard treatment with abemaciclib. And you have to do that within 16 months of your surgery. You see a few more points there. Clinical trials are a fantastic way here in New Zealand, where we're often running behind on access to new drugs and where they're often very expensive before they're funded, a fantastic way to possibly get access to these new drugs. And we're really hopeful that we might have a Palbociclib trial coming up soon. The Patina trial has been announced by the Australia New Zealand Clinical Trials Group. The Patina trial has been announced by the Australia New Zealand Clinical Trials Group. They will be running it in the region, and hopefully with one New Zealand site. Now that's a trial for people with ER positive and HER2 positive metastatic breast cancer. And in that trial, patients will be randomized either to receive standard anti-HER2 treatment like Perjeta or Herceptin with Palbociclib, or the same but without Palbociclib. There's a few more details there, but we can't say for sure that it's going to be happening. We hope it will be happening soon here in New Zealand, probably Auckland, but we'll keep you posted on that. So do talk to your oncologist and do keep an eye on our website for updates on that. Okay, so we're now going to open up to some questions from you at home. You can type questions in the box at the bottom left of your screen, which some of you have been doing already, and we'll get through what we can in the time remaining. So I've got a couple here already. So a couple of questions about, is it best to take palbociclib at the same time as letrozole, or can you start taking it after letrozole ceases to be effective?
Yeah, very good question. And again, it has come up in this discussion about, cost, right? Because we know that some people can do very well with letrozole or anastrozole alone, right? That's been the standard. The studies have shown that on average, women are on these drugs about 14.5 months. That's by themselves, and then they become resistant. But there are some women who actually go 24 months. The studies with palbociclib as well as the other CDK inhibitors show, though, that we cannot identify a group of women that does not benefit from the drug. That, whether it's their age or types of breast cancer, meaning in the bones or elsewhere, prior treatments, there's very much a consistent benefit to adding palbociclib to letrozole. Now, the data with fulvestrant does show that if you start with an aromatase inhibitor and it stops working, then fulvestrant and palbociclib is still very effective. The way I look at the data, though, is there's no data set that gives you a PFS of over 2 years, right? That's a very big number, and that, to me, is a compelling reason to use it up front, finances aside.
Right. Yeah. Okay, and by PFS we mean progression-free survival. So another question from the same person. If you start taking the palbociclib, do you need to keep on taking it? And is it best to start on it as soon as possible after your metastatic diagnosis?
So, all the studies have been done to continue it as long as you're responding. If we stop the drug, will that affect the response? I don't know for sure. I mean, I would think it does in some people. The nature of how we tend to treat these diseases is you continue what you have, especially for an incurable disease, right? I know we have many things that are active in advanced breast cancer, but we can't take them all for granted because eventually we run out of things to do. And if we have good disease control with the combination, I would be very hesitant to stop something without knowing what to expect. And the second half of that question was?
Is it best to start it as soon as possible after diagnosis?
Yeah, I mean, I think women always have time to get a second opinion, to look into a clinical trial, assuming they don't have symptomatic disease. Some women present with a very advanced tumor burden. They might have impending liver dysfunction or breathing problems. If they're symptomatic, they probably need treatment sooner. And in those women, what we term visceral urgency or visceral crisis, meaning they have tumor that's causing liver dysfunction, we would actually maybe even go to chemotherapy first to get a very rapid response. But short of those situations, I think you certainly have time to figure things out.
Now a question, if I have lobular cancer that's metastatic ER positive but inconclusive HER2 status, would you still recommend palbociclib with letrozole?
That's a good question. So it's actually a two-part question. In the New England Journal paper that we published, we actually looked at lobular versus ductal histology and showed that both of them got a significant benefit from the addition of palbociclib, even maybe a little better for the lobular group. But those were all confirmed HER2 negative. You should be able to figure out the HER2 status of a tumor because that is an important indicator. A tumor that is HER2 amplified does not respond as well to endocrine therapy alone, and the backbone would switch from endocrine therapy to HER2-directed therapy. And usually that can be determined on FISH testing or maybe some other molecular tests. But I think determining the HER2 status would be very important. If it is confirmed HER2 negative, I think this combination is proven to be of benefit.
Do you take the aromatase inhibitor and palbociclib at the same time of day?
Yes. You know, palbociclib is dosed once a day, and it's 3 weeks on, 1 week off, and that's to allow for the blood counts to come back. And that's why you heard that you might need to come to the office a little more frequently to have your blood counts checked to make sure it's okay to start. But yes, they typically can be taken at the same time every day. Even though you take a break from the palbociclib, you would continue the aromatase inhibitor continuously. There's no break.
And how soon might a patient expect to know if they're responding?
Good question. You know, in the research studies, scans were generally done either at every 2 or 3 month intervals. And because of that, we can say the average time to response is probably about 2 months, 2 to 3 months.
Okay. And how, if you're taking palbociclib in the adjuvant setting, so for the stage 3 locally advanced cancer, say, how long would you expect to stay on it? Well,
I'd like to be specific, right? You know, adjuvant means after surgery, and right now that's not approved, right? The Monarch E study, for example, is looking at abemaciclib in early stage breast cancer. So the women who right now the label in the U.S. as well as I assume here in New Zealand will be for women who have advanced disease. So certainly women who have large locally advanced tumors or with locally advanced lymph nodes could be a candidate for this drug. And again, I think in oncology we usually keep patients on drugs as long as they're responding and tolerating it well.
So in the Palace trial, I think you mentioned they were on it for 2 years, but that was in the adjuvant.
That was in the adjuvant, so that's after all their tumors been removed to see if it increases the cure rate.
Okay. And there are a few patients who are PR positive and ER negative. How would they be?
Yeah, they are generally treated as hormone receptor positive. We had some of them in our Paloma 2, the phase 3 study, and actually did some biomarker work with them. And they tend to get a benefit. We know that the women who are ER negative, PR positive, we do offer them anti-estrogen therapy, and they don't respond as well as the ER positives or the ER PR positives, but they're still treated as being hormone receptor positive and would be candidates for the addition of a drug like Palbo.
Do we have any more questions, Alice? No? Okay, so I think that's it on the questions. Anna, is there anything else you'd like to add to this discussion?
No, I think that sounds great. I mean, I think back to your question about this family of drugs in the adjuvant setting, you know, hopefully at some point we will have a clinical trial where we can, that would be the place to bring these drugs in terms of the adjuvant setting. If we could enroll patients in trials, that would be the way to go. So it's always worth asking your oncology team what trials are open in your city or at your hospital.
Great, thank you. Anything else you'd like to add, Dr.?
No, it's very exciting to be here and reach out to the New Zealand Kiwi community. And it's very gratifying to see you know, our work touching so many women around the world. But access certainly needs to be a priority.
It certainly does, and that's something we're very conscious in New Zealand that we really need to lift our game in terms of access to medication. Okay, so thank you so much, Dr. Finn and Dr. Bashford, for joining us today, and thank you all out there for taking time out of your day to join us as well. Our next webinar is in the evening of Tuesday, April 10. That's on fatigue after breast cancer, or indeed fatigue during breast cancer as well, and we'll have a fatigue specialist talking at that. If you have a moment to complete the exit survey as you finish the webinar, we'd really appreciate that. Otherwise, thank you very much for coming, and we'll see you next time. Bye.